Good morning. My name is Annie Austin, and I'm a nurse practitioner at Vanderbilt University Medical Center in Nashville, Tennessee, the stem cell transplant and cellular therapy team. And I'm joined by my physician colleague, Dr. Delaria, and I will be presenting on post-transplant infectious complications. I have no financial disclosures. And our learning objectives today will be to first discuss the clinical significance of infectious complications post-transplant. We'll also review the risk factors for infection post-transplant, as well as identify the most common types of infections post-transplant, focusing on bacteria, fungi, and viruses. And then we'll discuss nursing interventions to prevent infection post-transplant. So stem cell transplant, as most of us know, is a highly advanced technique. It offers a potential cure for an increasing number of life-threatening diseases. And we've made enormous progress in the last decade, including the refinement of donor selection and advancements in patient supportive care, has significantly improved transplant outcomes. However, invasive infection still represents a major source of morbidity and mortality in our transplant population. These tables on this slide were taken from an eBMT registry study that was published in BMT in 2020 and show the causes of death from transplant in recipients from all donor types and stem cell sources for AML, ALL, CML, and it includes the time period between 1980 and 2015. It's reported from 588 centers in 51 countries and includes data from over 100,000 patients. The data here was separated into two cohorts that you can see, cohort 1 from 1980 to 2001 and cohort 2 from 2002 to 2015. Infection is noted in both the light and dark green bars. And as you can see, among all transplant recipients, the main cause of death overall for all time periods was relapse. However, this was quickly followed by infections, which represented deaths in 23.8% of allogeneic and 14.8% in autologous transplant patients. And then GVHD was behind infections with 19% of allogeneic patients only. But that being said, infection remains either the first or second cause of transplant mortality in the first 100 days in both autos and allos. Thus, it's extremely important that we continue to develop methods to better prevent and treat infections in the post-transplant setting. So the ability of transplant to provide definitive cure without excess transplant-related mortality is really dependent upon the ability of donor stem cells to replace and restore all aspects of the innate and adaptive immunity. Individual components of immunity are restored at pretty distinctive rates depending on a variety of factors, including the type of transplant, the type of donor histocompatibility, donor stem cell source, donor and recipient ages, conditioning regimen, GVHD prophylaxis and treatment choices, and in vivo or ex vivo graft manipulation strategies, such as using ATG. Functional immune reconstitution begins with initial engraftment, and on average takes anywhere from several months to up to 2 years after transplant to complete. Recovery of the innate immune system components usually occurs first, followed by a slower and pretty variable recovery of the adaptive immunity. This graph on this slide depicts the approximate immune cell counts expressed as percentage of normal counts, peri and post myeloablative stem cell transplant. And following myeloablative conditioning, transplant recipients typically experience a period of profound pancytopenia that spans days to weeks, depending upon this donor source, typically shorter for PBSC G' grafts and longer for bone marrow and umbilical cord blood. So the yellow line here represents the innate immune cells, neutrophils, monocytes, and NK cells, which recover first and typically in that order. The green line represents the recovery of CD8 T cells and B cells. Those may transiently become like supernormal, as they are often transitional and naive, and then typically fall after that. And then B cell recovery is influenced by graft type, and it's delayed by GVHD and or treatment, and typically takes about 6 to 12 months to recover. The red line represents CD4 T cells, the recovery of which is influenced primarily by T cell content of the graft and patient age, and typically can take up to 1 to 2 years to reconstitute. So the types of infections of which transplant patients are most vulnerable can roughly be divided into 3 time periods. The first is the pre-engraftment phase, which starts at day 0 to day 20 to 30. Then there's the post-engraftment, which is any time from engraftment to day 100. And then late phase or late engraftment is any time after day 100. And dividing these periods really helps to delineate which infections are most likely and which clinical symptoms occur during each period. Being able to understand that helps us to figure out which pathogens are most likely during those periods, helps us facilitate decisions about the type of prophylaxis needed, and aids in the creation of more accurate differential diagnoses when you have a patient that presents with fevers or infectious symptoms. The timing and length of each period may vary according to the type of transplant, the source of stem cells, degree of HLA matching, the type and intensity of conditioning regimen used, and the type of immunosuppression and presence of GVHD. In general, all allotransplant recipients are at risk for infection during all 3 periods, whereas autotransplant patients are really only vulnerable during the pre and post-engraftment periods. So kind of running through each phase. During phase 1, prolonged neutropenia and breaks in the mucocutaneous barrier, think mucositis, colitis, cellulitis, typically result in substantial risk for bacteremia and fungal infections involving Candida species, and as neutropenia continues, sometimes Aspergillus. Additionally, herpes simplex virus activation occurs during this phase, but bacterial infections represent the most common pathogen seen during this time, particularly enteric gram-negative bacteria and gram-positive bacteria. Moving on to phase 2, infections relate primarily to impaired cell-mediated immunity, and the scope and impact of this defect is primarily determined by the extent of GVHD and immunosuppressive therapy for it. So you're going to see herpes viruses, particularly CMV, are common, as well as some other pathogens, including PJP and Aspergillus. And then finally, during phase 3, it's really impacted by, again, the degree of GVHD. So persons with chronic GVHD and recipients of alternate donor allogeneic transplants remain most at risk for infection during this period. And common pathogens include CMV, VZV, and infections with encapsulated bacteria such as strep pneumo. The relative risk, again, for these infections is pretty much directly proportional to the severity of the patient's GVHD during phases 2 and 3. And then just of note, the risk of disease from a community-acquired respiratory viruses is elevated during all 3 of these phases. However, in phase 3, the outpatient status of transplant recipients can complicate efforts to reduce exposure and provide timely intervention. So you might see an uptick of those types of viruses during that particular phase. So who's at risk for infection? Really, we can divide this into patient-related factors and then transplant-related factors. So patient-related factors include older age, high transplant comorbidity index, which we should be getting on all of our patients and calculating before coming into transplant to understand their risk. Disease status, seeing higher risk with more advanced disease at the time of transplant. Think about those patients are having more treatment prior to coming, usually prolonged neutropenia coming into transplant. Patients that have a history of extensive pre-transplant immunosuppressive therapy, so those that might maybe also have a compounding autoimmune disorder coming into transplant. Those who are coming for a second transplant. So if you've had a prior transplant, obviously your immune system has already taken a beating. So coming into transplant for another time puts you at higher risk for infection. History of pre-transplant infection in both the donor or the recipient, and then kind of going along with that is the presence of any pre-transplant specific immunity to CMV, EBV, HSV, and VZV. And then transplant-related factors, we think about the type of transplant. So you're going to see higher risk with allo versus auto, the donor type, higher risk with MUDs versus matched relateds, HLA match, higher risk with a mismatched graft, the graft type, higher risk with cord blood, typically intermediate risk with marrow, and then higher risk with T-cell depleted grafts. Time from transplant with a lower risk, obviously with more time elapsed from the transplant, so more time for the immune system to recover. GVHD, higher risk with grade 3 to 4 acute GVHD or extensive chronic GVHD, necessitating higher doses of immunosuppressive therapy. Conditioning regimen, higher risk with myeloablative intensity conditioning regimens. Thinking about those patients are going to have a more severe prolonged neutropenia than those undergoing a RIC. Immunosuppressive therapy regimen, higher risk is seen with ATG, as well as those that include methotrexate, typically due to an increased risk of mucosal injury with methotrexate. And then finally, neutrophil engraftment, we usually see a higher risk with delayed engraftment. So for the rest of the presentation, I'm really going to focus on different types of bacterial, fungal, and viral infections that are commonly seen during transplant. Obviously, each of these infections and topics could probably serve as its own presentation. So we'll kind of be running through quickly, but we'll have time for questions at the end. So if there's anything you want to know more in depth, please don't hesitate to ask. So for bacterial infections, the microbiology of bacterial infections in transplant patients has evolved a lot over time. In the past decade or so, it's been greatly influenced by the increased prevalence of C. diff infections, the evolution of conditioning regimens, and by the widespread use of fluoroquinolone prophylaxis, which is now pretty ubiquitous and has really helped to decrease the incidence and fatality of sepsis. But once transplanted, allotransplant patients in particular are at increased risk for bacterial infections for the remainder of their lifetime. Patients with profound, prolonged, which is greater than 7 days of neutropenia, are at particularly high risk for serious infections. Profound, prolonged neutropenia is most likely to occur in the pre-engraftment phase of transplant, and it's estimated that over 60 to 90% of auto and allogeneic patients will develop a neutropenic fever episode, and up to 85% of documented infections in neutropenic patients are bacterial. Because neutropenic patients are unable to mount robust inflammatory responses, serious infections can occur with minimal signs and symptoms. In those patients, fever is often the only sign of infection. So we really need to be pretty vigilant about instituting interventions quickly for these particular patients. They can progress rapidly, leading to life-threatening complications. And so ideally, we're trying to initiate antibiotics within a short time period. Typically, the gold standard is within 60 minutes of triage to delay progression to serious infections. We define neutropenia as an ANC less than 500 or an ANC less than 1,000 with a predicted decline of less than 500 within 48 hours. And then fever is defined as a single oral temperature of greater than or equal to 101 Fahrenheit, or an oral temperature of greater than or equal to 100.4 for at least 1 hour. Just to kind of summarize the slide, common bacterial pathogens in the pre-engraftment period include gram-positive, gram-negative, and anaerobic bacteria. We're particularly seeing an increased rise in C. diff, primarily related to the extensive antibiotic exposures of many of our patients, mucosal damage from intense chemo, multiple prior hospitalizations, as well as use of Levaquin, which is frequently given for bacterial prophylaxis in these patients. As mentioned, neutropenic fever is a medical emergency and thus should be treated promptly. An infectious workup should be obtained that at minimum includes blood cultures, UA urine cultures, chest x-ray, and any additional workup should be guided by the patient's presenting symptoms, such as the addition of a respiratory viral panel, C. diff, or more dedicated CT imaging. Antibiotics should be started within 60 minutes of presenting, with the aim of empiric therapy being to cover the most likely and most virulent pathogens that may rapidly cause serious illness or life-threatening infection. Ideal properties of an empiric antimicrobial regimen include something that's broad spectrum with anti-pseudomonal coverage, something that's bactericidal and that has minimal resistance per your institution's antibiogram. We typically do recommend removing central venous access if suspicious for infection or no longer functioning, and to de-escalate therapy once organisms and susceptibility are known. Our approach to neutropenic fever at Vanderbilt is in agreement with current guidelines and begins with the initiation of monotherapy with an anti-pseudomonal beta-lactam agent, such as cefepime. We then use an algorithm that assesses the need for additional gram-positive coverage if the patient demonstrates clinically suspected serious catheter-related infections, colonization with MRSA or VRE, blood cultures that are gram-positive while pending ID and susceptibility testing, severe mucositis, severe sepsis or hemodynamic instability, soft tissue or skin infection, or radiographic evidence of pneumonia. We typically only use Zosyn if there's intolerance to cefepime and concern for an intra-abdominal process. And if a patient continues to fever for 48 hours, we then assess the need for addition of vancomycin if not already added, or consider additional infectious workup as well as potentially getting ID on board. So during the early period after engraftment, the risk of bacterial infections and bacteremia is reduced but ongoing. The risk is increased by general debility, by the presence of renal or hepatic dysfunction, and by the presence of GVHD. Central venous lines are often the most common source during this period, and most of the patients by this time will have received antibiotic courses, making them more likely to be infected with resistant pathogens. Staphylococci, enterococci, most often VRE, and non-fermenting gram-negatives such as Stenotrophomonas, Maltophilia, and Acinetobacter are frequent pathogens as well. During the late period following engraftment, the main predisposing factor for infection is the presence of GVHD. Many patients have B-cell dysfunction and are functionally asplenic. They are thus vulnerable to serious infections with encapsulated bacteria, most notably Streptococcus pneumoniae, with pneumonia as the usual source. Less common infections are due to mycobacteria and nocardia. The risk of bacterial infection can be reduced by the use of prophylactic antibiotics. In general, fluoroquinolones are the preferred agent, usually Levaquin, due to their broad gram-negative and gram-positive coverage that includes Pseudomonas. If there's an allergy to quinolones or a contraindication, you can consider Ceftin or Augmentin. Prophylaxis should typically start with a stem cell infusion, or indoor should continue until the resolution of neutropenia or the initiation of antibiotic therapy for neutropenic fever. In addition, the length of neutropenia can be mitigated through the use of GCSF support during this time. At our center, we initiate this at day +5 for all autos and haploidentical transplants. When autos engraft, bacterial prophylaxis typically can be stopped. For allos, we typically switch bacterial prophylaxis to penicillin at day 30 for better coverage of encapsulated bacterial pathogens, and continue this until the patient comes off of immunosuppression, which is typically late post-engraftment. If the patient develops GVHD and requires higher doses of steroids, bacterial prophylaxis should be adjusted to cover the most likely pathogens. Prevention of infection late post-engraftment really focuses on vaccination of relevant bacteria, beginning around 6 months post-transplant to restore adaptive immunity, as well as using IVIG for those that are B-cell deplete and hypogammaglobulinemic. So moving on to fungal infections, invasive fungal infections are a major cause of morbidity and mortality among transplant recipients. Individuals undergoing allotransplant are at higher risk for developing IFIs, invasive fungal infections, compared to recipients of autografts, largely owing to delayed engraftment and GVHD. The epidemiology of IFIs in transplant remains pretty dynamic and has changed a lot over time. Since the 1990s, there's been a decrease in the incidence of invasive candida among transplant recipients due to the more widespread use of fluconazole prophylaxis. However, IFIs due to Aspergillus and other molds are on the rise. In the early pre-engraftment phase, candida are more common. However, most fungal infections are seen during the early post-engraftment and late post-engraftment period. So as mentioned, prior to the routine use of antifungal prophylaxis, candida accounted for the majority of fungal infections, followed by Aspergillus, but Aspergillus has now surpassed candida as the primary cause of invasive fungal infections in transplant recipients. Although candida is ordinarily a harmless colonizer on mucosal surfaces and skin, breaches in the skin or mucosal integrity can lead to invasion of deep tissues and hematogenous dissemination. The most benign infections, as most of us know, are characterized by local overgrowth on mucous membranes, such as in the oropharynx or causing vaginitis as a result of changes in the normal microbiota. However, in severe circumstances, candida can become invasive and gain entry via the GI tract or via indwelling catheters. Candida albicans accounts for about 50%, I think, of invasive candida infections, and transplant recipients are also at increase, though, for infection caused by non-albicans and azole-resistant candida species, such as Galbrata and Cruci, compared with other types of patients. The clinical manifestations of infection with candida range from local mucous membrane infections to widespread dissemination with multi-system organ failure. Invasive candida in allotransplant patients most commonly presents with fungemia or hepatosplenic candidiasis. The diagnosis of invasive candida remains pretty challenging, particularly in those with deep fungal infections, such as hepatosplenic candidiasis, which commonly has negative blood cultures. In this situation, CT of the abdomen is usually helpful and demonstrates multiple lesions in the liver and spleen, and biopsy is typically required to secure a diagnosis. Newer diagnostic assays, including beta-D-glucan, which detects beta-glucans in the cell wall of molds and yeast, may be valuable in a diagnosis, and we do typically order them when we're trying to rule out fungal infection. However, they are not definitive for diagnosis. Treatment for invasive candida involves prompt initiation of antifungal therapy and should be guided by susceptibility testing. Given the prevalence of azole-resistant candida species in neutropenic patients, management of invasive candida should include an echinocandin such as caspofungin or micafungin or Ampho-B. Several studies have demonstrated comparable efficacy between both antifungal classes. However, echinocandins have been associated with a more favorable toxicity profile and thus are typically preferred. In non-neutropenic patients who are not critically ill and who don't have a fluconazole-resistant organism, flute can be used as an alternative. And Ampho should really just be reserved for those with intolerance or resistance or contraindications to an echinocandin due to the high toxicity profile. Guidelines for CBC removal typically depend on neutropenia, though it is typically advised to remove a CBC if it is infected. Durations typically guide by the extent of disease and the clearance of blood cultures if they were positive. Those who are acutely ill with candidemia should be treated for a minimum of 2 weeks after clearance of blood cultures, and you can typically use a fluconazole step-down approach for those that are clinically stable and have clearance of blood cultures. Those with more invasive or hepatosplenic disease typically require a much longer duration of therapy, typically involving 3 to 6 months. Aspergillus are the most common causes of IFI, as mentioned, in transplant patients now. While both auto and allos are at risk for invasive aspergillus, prolonged neutropenia and GVHD contribute to higher incidences among allo recipients, with a reported incidence of about 8 to 24% compared to 1 to 2% for autos. Aspergillus is a common mold. We find it in dead leaves, stored grain, compost piles, or in other decaying vegetation, and it can gain entry via the airborne route via inhalation into the sinuses or the respiratory tract. Invasion occurs either via the vascular route during neutropenia, so you might see an uptick in that kind of first pre-engraftment period due to host immunosuppression, and then it can also happen via local inflammation in the form of airway invasiveness in non-neutropenic patients, usually during long-term use of steroids or immunosuppression as a result of GVHD. The lungs are the most commonly involved site, though patients may develop sinusitis, CNS disease, and tracheobronchitis. Clinical presentation is pretty variable, but frequently involves a fever, cough, chest pain, hemoptysis, and/or respiratory failure. Diagnosis can be pretty challenging, but typically involves CT of the chest or sinuses. Based on clinical presentation, you're typically going to see GGOs with, ground glass opacities with surrounding halos, nodular infiltrates, and cavitations are pretty suspicious for invasive aspergillus pneumonia. However, this is pretty nonspecific, so we typically do recommend bronchoscopy to be pursued and gain either a Aspergillus galactomannan on the sample or a biopsy. Beta-D-glucan can again be used to aid in diagnosis, but it's not specific and should not be used alone. Empiric therapy for suspected invasive aspergillus should include a mold-active azole or liposomal amphotericin B. The use of an echinocandin can be considered, though these agents are fungistatic rather than fungicidal and should only be used when combination therapy is warranted. It's important to consider the likelihood of resistance when choosing initial therapy. Antifungal resistance is being detected with increasing frequency in some geographic regions and is more likely to occur with certain aspergillus species. If the diagnosis of invasive aspergillus is confirmed, primary therapy typically should include VORI in most patients, as this agent has been associated with improved clinical outcomes and survival rates, and it's less toxic compared with amphotericin B. But for those patients who can't tolerate VORI or for whom it's advisable to avoid its side effects, POSA and Cresemba are the preferred alternatives. For patients in whom you may suspect an invasive mold, but you don't have a confirmed diagnosis of invasive aspergillus, typically it's advised to use Ampho-B as an empiric treatment because it covers both aspergillus and other molds such as mucor. Duration of antifungal therapy, again, is really dependent upon the location of the infection, the patient's underlying disease, and the need for further immunosuppression. Antifungal therapy is usually continued until all signs and symptoms of the infection have resolved, and often longer in patients with persistent immune defects. Typically, we're really going with ID expertise in this situation, your infection disease team. Oftentimes, radiographic abnormalities need to either have stabilized or completely resolved before stopping therapy. So usually, you're treating for a minimum of 6 to 12 weeks. Quickly touching on some other molds that we see in the post-transplant setting, including Zygomycetes and Fusarium. Mucor and Rhizopus species are the most commonly encountered zygomycetes in clinical practice, with an incidence of 8.5 and 5.9%, and recipients of match-related and match-unrelated transplants, respectively. Infection with these organisms results in mucormycosis, which can occur in late post-transplant period and causes devastating sino-orbital, CNS, and GI disease, as well as cutaneous lesions and fasciitis. If you have a patient with this, typically you will never forget it, as unfortunately the mortality rate is quite high. These organisms are ubiquitous in nature and can be found on decaying vegetation and in the soil. And among transplant recipients, risk factors for this include HLA mismatch, prolonged neutropenia, corticosteroid use, iron overload, and GVHD. Fusarium is pretty uncommon. It's also an environmental organism, but again, has a pretty high mortality rate. Cases of fusariosis among transplant recipients have been linked to contamination of CBCs and hospital water supply. The onset of fusariosis typically occurs in a bimodal fashion, kind of similar to Aspergillus. So you're going to see upticks both in the early post-transplant, like the pre-engraftment period, due to prolonged neutropenia. And then again, you might see an uptick in late infections in the late post-engraftment period after day 100. Risk factors for fusariosis include underlying multiple myeloma and HLA mismatch. An infection can actually mimic invasive aspergillosis. However, patients with fusarium typically have positive blood cultures and multiple papular or ulcerated skin lesions compared to patients with invasive aspergillus. Diagnosis relies on histopathology, and treatment for both first line is with liposomal amphotericin B. Duration is really guided by the extent of the infection and typically with the help of an ID team. For Mucor, oftentimes you're needing to consult other specialty teams like ENT and thoracic surgery because sometimes these patients end up needing surgical debridement. Again, as mentioned, prognosis is very poor with both of these types of organisms in immunocompromised host, with mortality rates as high as 60 to 80%. So fungal prophylaxis, should be noted that there's some controversy about the use of antifungal prophylaxis and what's recommended. In addition, the need for antifungal prophylaxis really depends in part upon local rates of resistance, as well as the overall risk of invasive fungal infections based upon which transplant regimens are used. As a result, practices regarding antifungal prophylaxis may vary pretty widely between cancer centers. So what I'm presenting here is what we do here at Vanderbilt, but just kind of understand that it may be different depending on your geographic region. We typically start prophylaxis day -1, similar to antibacterial prophylaxis in anticipation of neutropenia. Our preferred agent is fluconazole, 400 milligrams orally daily. However, we do frequently use micafungin for some patients, particularly those with elevated LFTs, increased risk for veno-occlusive disease, prior inotuzumab, those with drug-drug interactions where fluconazole is contraindicated, and those with prolonged QT. You should consider IFI prophylaxis in certain patients, so patients that are increased risk for more invasive molds, such as those with a history of IFI, prolonged neutropenia prior to transplant, so your aplastic anemia patients, haploidentical transplant patients, cord blood transplant patients, and those on high doses of steroids. In this setting, you really should be choosing posaconazole. However, at our center, for haploidentical transplant patients, we typically use micafungin due to the higher risk of VOD and delayed engraftment that's seen. Our duration for autos, we typically continue through engraftment, and then for allos, we typically continue at least through day 100. Just a note on PJP, also a potentially life-threatening infection that occurs in immunocompromised individuals. Due to effective prophylaxis, PJP has become a pretty rare event among allotransplant recipients. It is recognized as a fungus and it's transmitted via the airborne route. It's usually a late occurrence, and risk factors include treatment for GVHD or cessation of PJP prophylaxis. Despite effective treatment, mortality can be pretty high if infection occurs early after transplant. And clinical manifestations typically include fever, dry cough that quickly turns into pneumonia, and fulminant respiratory failure. Typically, you can distinguish this from other pneumonias due to the development of pretty severe hypoxia. The definitive diagnosis of PJP requires identification of the organism either by a dye-based staining, fluorescent antibody staining, or PCR-based assays of respiratory samples such as induced sputums or a BAL or tissue biopsy. For allo patients, consideration of pre-transplant toxo serostatus is really important, as Bactrim typically is the preferred agent because it covers both PJP and toxo. Atovaquone also covers both of these, but it does have a higher toxicity profile, so we typically do prefer Bactrim in this setting. For auto patients, PJP prophylaxis is not required unless they have experienced additional immunosuppression prior or during transplant. And given the risk of myelosuppression with these agents, as well as the fact that PJP does not typically occur during the early pre-engraftment phase, it's recommended to wait to start PJP prophylaxis until day 30. And then we usually continue it until patients are off immunosuppressive therapy. And occasionally you can check CD4 counts to ensure that's greater than 200 before stopping. So moving on to viruses. Viral pathogens are also a significant source of morbidity and mortality after transplant. Allotransplant patients are affected by a wide, allo and auto, are affected by a wide range of viruses, either through primary infection, donor-derived infection in the case of allo, or reactivation of latent viruses. Infections due to adenovirus, BK, as well as the respiratory infections can really occur at any time during the transplant process. HSV1 and 2 are mostly seen pre-engraftment, whereas infections due to CMV, HHV6, HHV8 are seen in the early post-engraftment phase, and EBV and VZV are most often seen after day 100. Unlike in the general population, where typically viruses, the clinical manifestation of viruses are typically mild and range from like asymptomatic carriage to mild to moderate symptoms, transplant recipients may develop much more severe disease. Thus, identifying patients at risk for reactivation of latent viruses or acquisition of new ones is pretty important, as active infection diseases can be prevented with preemptive monitoring or tailored prophylaxis during the most critical periods. For purposes of this lecture, I wish I could talk about all of these viruses, but I'm really going to focus on the ones that we actually have prophylactic strategies for. So CMV is a globally widespread virus that becomes latent following primary infection, but reactivates frequently and causes death in stem cell transplant recipients in the setting of immunocompromise. It's a member of the herpes virus family and can be transmitted via sexual contact, blood, urine, tissue, saliva, and breast milk, among others. It's estimated about 50% of the US population is latently infected with CMV, but in other places in the world, including developing nations, the prevalence is even higher. Prior to widespread use of anti-CMV prophylaxis, about 80% of seropositive allotransplant recipients develop CMV reactivation, usually in the first 3 months after transplant. However, we do have CMV prophylaxis now, but it's still, we do still see an instance of CMV reactivations upwards of 20 to 50% after transplant. It can occur in auto-transplant patients, but is much less common and much less fatal and has a much lower risk of developing into CMV significant disease. Clinical manifestations of CMV disease are variable and include interstitial pneumonia, enteritis, hepatitis, retinitis, encephalitis, and a CMV syndrome that includes cytopenias and fevers. Diagnosis of CMV disease remains pretty challenging given the varied and nonspecific presentations. And although PCR analysis of CMV DNA in the serum has become like the mainstay to help assist with diagnosis, there's really no absolute cutoff, and different centers have different assays that use different sensitivities, different cutoff values. So there's really been no established guideline for that. Diagnosis for CMV disease thus should really be based on pathology findings from either the lung or GI biopsies, depending on where symptoms are presenting. CMV-related mortality is about 40 to 50%, but can be as high as 86% in cases of severe CMV pneumonia. Classic and most important risk factor for CMV reactivation is the serostatus of the recipient and the donor, with a CMV-infected patient receiving a graft from a CMV-naive donor considered the highest risk due to lack of donor-transferred CMV-specific immunity. Additional risk factors include TBI in the conditioning phase, development of acute and chronic GVHD, T-cell depleted grafts, mismatched or unrelated donors, post-transplant cytoxin, and high doses of steroids. The best way to prevent CMV is to choose a CMV-negative donor for CMV-negative recipients when possible. When this is not possible, it's best to prevent CMV by using either a prophylactic and/or preemptive approach to therapy. Letermovir is a relatively new antiviral agent that was approved by the FDA in 2017 to prevent CMV in allotransplant recipients. It's an oral agent. It inhibits the CMV terminase complex to prevent CMV replication. It has no cross resistance with other antiviral agents and has a favorable side effect profile, which makes it really ideal to use in the prophylactic setting. It's indicated for MUD recipients. If the donor recipient is CMV positive, we use it in cord blood transplant recipients and patients receiving post-transplant Cytoxan, and those receiving greater than or equal to 20 milligrams per day of prednisone equivalent, and in those on Jakafi. We typically start day +5 and continue through at least day 100. CMV monitoring can help to catch CMV reactivation early before it causes clinically significant disease and thereby initiate early preemptive therapy. The frequency and duration of monitoring, again, depends on the type of transplant, the history of CMV infection or disease, and the allograft manipulation. We typically at our center recommend monitoring weekly. And we don't typically do that frequently on autos. We just typically do it at engraftment and then don't do it again unless there was concern for CMV related disease. Most centers use PCR assays, and this is preferred because of their greater sensitivity. But again, there is no established cutoff value. Historically, the accepted threshold is about 500 to 1,000 copies per milliliter before you would initiate preemptive therapy. IV ganciclovir is first-line therapy for CMV disease. In non-severe cases, including asymptomatic viremia, you can consider using oral valganciclovir. Foscarnet and cidofovir have pretty high toxicity profiles, so those are typically reserved for second-line therapy for those that either have ganciclovir resistance or where you are unable to use ganciclovir for whatever reason. Typically, therapy is continued for about 14 to 21 days once CMV is negative in the blood, followed by about 1 to 3 months of maintenance therapy. HSV and VZV. So HSV, super common infection. More than 50% of US adults are latently infected with HSV1. HSV1 is more common than HSV2, but they are both acquired via the oral or genital routes and remain dormant in local nerves. In allotransplant, patients who don't receive antiviral prophylaxis, which should be very rare, hopefully in this day and age, the rate of reactivation can be as high as 80% and often occurs earlier, 2 to 3 weeks post-engraftment than other herpes viruses. Clinical manifestations of HSV1 typically are oral labial lesions, esophagitis, can be varied and cause some bone marrow suppression occasionally, keratitis, pneumonia, hepatitis, as well as some meningoencephalitis. HSV2 is less frequent and usually involved with perennial lesions only. And like other viral infections, donor immunity to HSV is an important predictor of the frequency of mucosal and visceral HSV disease in allotransplant patients, especially in those that are seropositive coming into transplant. VZV, similar to HSV, reactivation is the most common cause of VZV-related disease after allotransplant, occurs in about 16% of patients in the first year. People have been infected with VZV have lifelong latency of the virus in the dorsal root ganglia. Most VZV infections after transplant, again, are due to reactivation of endogenous virus in seropositive patients, and it typically occurs late in the post-engraftment period. Since anti-HSV or CMV prophylaxis is effective against VZV, reactivation usually occurs after prophylaxis has been stopped, but breakthrough infections can occur. Risk factors include GVHD, advanced age, immunosuppressive therapy, and HLA mismatch. And clinical manifestations typically include classic or multi-dermatomal shingles, with lesions usually taking longer to heal in immunocompromised patients. Disseminated VZV can happen. Typically, it's quite rare, but if it does, it usually will involve the lungs, liver, and the CNS. So HSV and VZV prevention, fortunately, we now have great coverage for that and typically use either oral acyclovir or valacyclovir. It's warranted in essentially all transplant patients. We prefer valacyclovir, given its greater bioavailability and the need for high levels of active acyclovir to inhibit VZV in vitro. Ganciclovir is also active against HSV and VZV, but it's much more toxic, and hence we don't typically routinely use these for prophylaxis. Although there's some variation and recommendation from consensus panels, most institutions have adopted a long-term prophylaxis strategy, At our center, we recommend prophylaxis for at least 6 to 12 months for autos and at least 12 months after allo transplant. Additionally, immunization post-transplant with the VZV vaccine should be given at greater than 12 months after transplant, providing there's no GVHD or ongoing immunosuppression at the time that would make the vaccine likely ineffective. Management of both HSV and VZV utilizes higher doses of valacyclovir or IV acyclovir, with treatment really being directed by the extent of disease. So you're going to use higher doses of IV acyclovir for patients that have either disseminated or deep tissue HSV or more visceral VZV. So finally, Epstein-Barr virus. It's another herpes virus that's extremely common with an incidence of established latency in 90% of adults worldwide. It enters the host via epithelial cells and B cells in the nasopharyngeal tract after contact with saliva carriers. Think mono that we've all heard of kind of early on in life, and establishes a lytic infection, which ultimately becomes latent in memory B cells, which is then held in check from reactivation by our cytotoxic T cells. In the setting of immunocompromise, unfortunately, though, these B cells can escape from cytotoxic T cell surveillance, which often gets wiped out with the use of T cell depletion strategies, and then allowing those B cells to proliferate, which can ultimately lead to detectable copies of EBV in the blood and occasionally EBV PTLD. EBV viremia is distinguished from EBV PTLD. They are not the same thing. And EBV viremia is simply defined as detectable EBV DNA in the blood. It can occur really anytime, but most often occurs within the first 6 months. An incidence of about 0.1 to 63%, which is a pretty wide variability. And the reason for that, again, is that centers use different assays, sensitivity, different defined levels of viremia, and different timing of how often they're screening patients. At Vanderbilt, we use a cutoff of 35 milliliters per copy or copies per milliliter. EBV viremia in patients is typically asymptomatic, though you can see some kind of like fever syndromes or cytopenias occasionally. EBV PTLD, on the other hand, usually occurs in the first year after transplant and arises when EBV-specific T cells are depleted, allowing for unchecked proliferation of donor-derived monoclonal or polyclonal B cells. The spectrum of PTLD includes extranodal lymphocyte infiltration to high-grade B cell lymphoma and varies from an indolent to fulminant presentation. Although the overall incidence of EBV-related PTLD in this population is about 1%, mortality can be as high as 50 to 90%. And clinical manifestations are pretty variable, but they often do include those characteristic B symptoms, so fevers, night sweats, weight loss, cytopenias, lymphadenopathy, and can involve some extranodal sites as well. Diagnosis is made via tissue biopsy, and staging is done via a PET-CT. Risk factors for EBV and EBV PTLD can be divided between pre-transplant risk factors and post-transplant risk factors. Pre-transplant, we see higher risks in those that are older, so greater than 50, those that have had a splenectomy, those in which patients have an EBV serology donor-recipient mismatch, particularly when the recipient is EBV negative and the donor is EBV positive, as unlike some of the other viruses, EBV is primarily donor-derived. And then really the biggest one is T cell depletion, which we see most commonly when ATG is used. Also see higher rates of EBV and EBV PTLD in cord blood transplants, HLA mismatch, and second transplants. And then post-transplant risk factors include severe acute or chronic GVHD due to increasing needs for immunosuppressive therapy and high-dose steroids, as well as those with higher rising EBV viral loads. EBV prevention and treatment. So really we can divide this into prophylaxis strategies, preemptive therapies, and true treatment. Prophylaxis, we do EBV testing pre-transplant of both the recipient and the donor and really try and select an EBV seromatched or seronegative donor. We employ frequent EBV PCR monitoring, typically starting at 30 days and continuing for at least 4 months post-transplant. Preemptive therapy is any intervention that's given to a patient with EBV viremia to prevent EBV disease and PTLD without clinical symptoms, with the goal being to obtain a negative EBV PCR below the threshold of positivity. Again, that cutoff values varies depending upon the institution, we typically use a cutoff of 1,000 as far as when we initiate preemptive therapy. Preemptive therapy, the mainstay of therapy, is using Rituxan once weekly for 4 doses or until EBV PCR is negative. This is effective in about 80% of patients. You also should be considering reducing immunosuppressive therapy if possible and combining that with Rituxan. However, sometimes that can be limited due to aggravation of GVHD, and you often, if you use it alone, has a slower response time to seeing those EBV levels decrease. We always would consider using CTLs both in prophylaxis and preemptive therapy, and that's cytotoxic T lymphocytes that are directed against EBV. I think we're hopefully going to see a lot more of that in the future, but unfortunately right now the availability of those is pretty limited depending upon the center. Treatment goal is really to resolve all signs and symptoms of PTLD and to obtain a negative EBV PCR. First line is Rituxan with or without reducing immunosuppressive therapy. Rituxan alone has a response rate of about 70% in those with confirmed EBV PTLD, and this increases to 80% when used with reducing immunosuppressive therapy. Second line includes cellular therapy in the form of DLI versus cytotoxic T lymphocytes, as well as chemotherapy plus or minus Rituxan. So nurses, as we all know, are really integral in helping us prevent infections in the transplant patient setting. I like to say that infections and nurses have a common denominator. They're there for the patient pretty much 24 hours a day, 7 days a week, and both are fighting to win. Fortunately, I think our nurses do an incredible job at starting the conversations around infection control right at the start of transplant and through the entire transplant process. Obviously, the biggest intervention that nurses can do is to educate our patients. They provide extremely important education on hand hygiene, dietary restrictions, masking, and when to isolate, food safety and food safety handling, and then also just how to identify signs and symptoms of infection. So when to give us a call if they should be concerned. In the pre-engraftment period, nurses are integral in implementing oral care and oral hygiene strategies to prevent mucositis, which thereby hopefully diminishes translocation to ultimately leading to bacteremia. Implementing meticulous central line care, strict eyes and nose. Sometimes that can be the first indicator if they're seeing any signs of blood in the urine indicating cystitis or diarrhea. Skin assessment, noting any sources for portals of entry if there's wounds or rashes, implementing protective isolation when needed, and also implementing CHG bathing to hopefully decrease both hospital-acquired and colonization with drug-resistant organisms. Early post-engraftment, again, focuses on everything I mentioned before as central line care, because those are the primary bacterial infections that we're seeing during that time, and as well as ensuring medication adherence. For us, oftentimes it's the nurses that are letting us know if the patient is having trouble with taking any of their prophylactic medication or having trouble with the tolerability or side effects of them, letting us know that we need to make a change. And then late post-engraftment, it's nurses that are giving vaccines as well as providing education on the importance of vaccination in the late post-engraftment setting. So in summary, infections are a significant cause for morbidity and mortality post-transplant. Understanding the timeline for immune reconstitution post-transplant can be extremely useful in identifying the most likely pathogens and creating your differential diagnoses when you have patients that are presenting with infectious signs or symptoms. Prophylaxis that's personalized to the patient and the type of transplant is really the mainstay of prevention. And nurses, of course, are essential in infection prevention and treatment strategies. Thank you so much for your time. We'll now respond to any questions in the chat bot or otherwise.
And that was wonderful, Annie. Very comprehensive review and kind of covered pretty much all the aspects of infectious complications and monitoring and the treatment. So thank you so much. It was wonderful. So I had a few questions, nothing active right now. I took care of, there was one question regarding the EBV monitoring and everything. So with the increasing use of the CAR T cell therapy for hematological malignancy, I know we didn't specifically cover here, but I wonder if you can give us your perspective on Do you treat this patient any differently compared to an auto transplant or allogeneic transplant recipient? I'm sure many of our participants are working at the centers where they are either doing CAR T cell therapy or about to start. So.
Absolutely. Yeah. So really in the CAR T setting, the biggest concern is that these people are going to be hypogammaglobulinemic for much longer, so much more B cell deplete. So these are people that you're really going to need to be monitoring for viruses as well as those encapsulated bacteria because they're essentially aspletic after CAR T. So those are the people that we do actually, and unlike autos, they do need PJP prophylaxis in the long-term setting. And we do monitor IgG levels frequently at Vanderbilt. I know Nancy probably mentioned this on the last webinar, but she is pioneering our long-term CAR T clinic. And a big portion of that role is monitoring for infection. So I think in the CAR T setting, we're seeing more of kind of similar complications that we would see in sometimes the late post-engraftment period for allos, actually, because of the prolonged immune constitution, particularly in B cell lines.
Okay. We don't have any active questions. I encourage participants to put in the chat box, even if they have some unique experiences with their centers or any challenges in managing complicated cases. We're happy to go over here. Let's see here. There's a question. Thank you for comprehensive talk. Are you giving penicillin for post-engraftment in all patients or only for patients with sickle cell anemia?
Good question. We do it for all allo transplant recipients. That obviously does include sickle cell anemia. So not in your auto patients, but all allos, again, given primarily due to that increased risk of encapsulated bacteria. So penicillin, we continue through essentially, I think until they're off immunosuppressive therapy in all allogeneic transplant patients.
Yeah, again, there is a variation among the transplant centers and the doctors. Of course, when it comes to bacterial prophylaxis, we at our center tends to continue penicillin or ceftin prophylaxis till they're off immunosuppression. If somebody especially has a history of chronic graft versus host disease, these patients are functionally immunopaired, and even if the low-dose steroids, they tend to get a lot of pneumococcal H influenza infections or recurrent bronchitis. So we tend to keep them on prophylaxis and replace their IVIGs for IgG level less than 400. At our centers, we tend to use low-dose IVIG, so 10-gram flat dose, and that historically in our experience that has actually worked out very well for our patients, and it's actually quite cheaper than giving the 0.4, 0.5 grams per kilogram, just a standard dose. No active question right now. And one issue I always kind of wonder in our practice is the CMV viremia. So as you mentioned, we tend to prophylax most of our patients with letermovir at least through the first 100 days. And beyond that, really the practice is quite heterogeneous, so to say. So once the letermovir is stopped for primary prophylaxis, what is the practice at your center and patients once they have transitioned to long-term care? Do you continue the letermovir? How often you monitor CMV? And if they do have CMV reactivations or disease and you treat them at Valsite, after they have cleared the CMV infection, do you put them back on letermovir for secondary prophylaxis? What's your take on this?
Ooh, that's a great question. And actually, feel free to jump in as I'm primarily in the early transplant care of patients, but typically we continue letermovir prophylaxis. As my understanding, unless there is any chronic GVHD or increased immunosuppressive therapy needs until they're kind of what we say first long-term visit. So early post day 100, consider removing it. And then from there, we're monitoring CMV at each long-term visit, which is typically monthly for patients that are not experiencing any severe complications post-transplant. If a patient was to have CMV reactivation, once letermovir prophylaxis is stopped, obviously, as Dr. Delaria mentioned, we do initiate ganciclovir or IV ganciclovir, depending on the nature of disease. And my understanding is they would be on maintenance therapy with that for quite a while after they clear CMV from the blood, but I am not as clear on whether we do initiate letermovir prophylaxis after that. I would think that we would, given the setting of a high risk for reactivation in that setting, but that would likely be my recommendation.
Yeah, so again, that's a data-free zone. There was the phase 3 long-term letermovir prophylaxis trial presented at a recent HCT meeting from City of Hope. And Memorial Sloan also has done a small prospective trial on using the secondary letermovir prophylaxis with some positive data, really. So at our center, as long as the insurance allows us, we tend to put them back on letermovir after they have cleared their initial CMV viremia or CMV organ-specific disease. In my practice, anybody with chronic graft-versus-host disease who is requiring higher doses of prednisone, so higher dose will be more than 20 milligrams per day, or any second line or third line CMV-directed therapy, such as ibrutinib, Jakafi, or belimumab. I tend to put them back on letermovir prophylaxis at that point, because you kind of keep seeing the CMV blips, and sometimes patients get into trouble with CMV disease. We have two questions. One is, in your practice, treatment of Clostridium difficile infection during the HCT. So what is our preferred treatment for C. diff colitis? And do you treat patients who are asymptomatic but has C. diff colonization? So that's part of one of the patient. Part two of the question is, do you do screening stool culture, which is a very interesting question for recipients who are about to undergo CAR T-cell therapy or stem cell transplant?
So I'll kind of answer them, I guess, in reverse order. We do not do, at this time, we're not doing any routine stool sample screening going into CAR T-cell therapy or transplant, though I do, of patients that have a prior history of C. diff going into transplant, we do recommend prophylaxis during the pre-engraftment period due to the risk of reactivation in that situation. So usually those patients are going to be on oral vancomycin, not at treatment dose, but typically at prophylactic dose during that period of time. And then we can stop that typically once they've engrafted. As far as the other questions related to what is our preferred treatment strategy for severe C. diff, we do utilize oral vancomycin as first line, which I believe is still in line with IDSA guidelines. However, I know that there is push also to consider second line with fidaxomicin. I think right now is the preferred second line agent if someone were to fail initial therapy. And then as far as patients with C. diff colonization, that is really a hot topic. And we only recently, I think, are creating a standard operating procedure for this particular scenario. For those that are, and Dr. Jalaria, correct me if I'm wrong, because we literally, I think, just really started implementing this into our practice, but those that are colonized, or like if they are develop diarrhea and you do a C. diff test and it comes back that they are, PCR positive, but toxin negative, we do typically implement therapy if they are having severe GI symptoms, is my understanding right now, is what our practice is. So we will initiate the PO vancomycin therapy in that situation if, let's say, a patient has also compounding typhlitis in that clinical picture.
That is correct. It becomes like a judgment call, in my opinion. Yeah. Many times these patients will have chemotherapy-related colitis. You're also working them up for graft-versus-host disease, acute graft-versus-host disease specifically. So certainly in this kind of situation, I would always recommend that look for all the other etiologies. So make sure that you do the endoscopy, do the biopsy to rule out the CMV colitis or other GI pathogens other than C. diff if the tox screen is negative. Also rule out graft-versus-host disease, but we tend to implement therapeutic dose of vancomycin in those situations where in occasionally case-by-case basis, which are colonized. The second question is letermovir is used for adult and pediatric patients? So I can answer that, Annie. So the current FDA label for letermovir primary prophylaxis is only patients about age 18. the pharmacokinetics has not been established and safety has not been established, although there were a few retrospective institutional experience of using letermovir for pediatric patients undergoing hematopoietic cell transplantations, but as of now, it has not been received FDA approval, at least in the United States. I'm sure at some point that will change for sure. Okay. Well, looks like we don't have any additional question at this point. I would like to thank Annie for giving this wonderful, comprehensive talk and kind of going over our questions. Feel free to reach out to either of us if you have any questions regarding our center practices or any challenging cases. We are always love to hear from every one of you and improve even our practice, because you always learn from other centers. So thank you so much.
Thank you all. Sorry for the momentary lapse in the presentation, but thank you for bearing with me.